So today, Saturday, and let's see how many of you are up for a discussion or already planning for weekend. Anyway, so today we had a mix of questions from all the ophthalmology topics. So one question each, so 10 questions. Okay, shall we start? Yeah. Okay. So first question is investigation of choice for Best's disease. Now this is a previous year question. See, Best's disease is a topic that they love, and there are just very limited things that you need to know about Best's disease. Now Best's disease, actually that's not the name that we use nowadays. It is called vitelliform macular dystrophy. So probably the next time you encounter this question, they would not say Best's disease, they would probably ask you investigation of choice for vitelliform macular dystrophy, okay, VMD. So the investigation of choice is electrooculogram. There are no two ways about it. There's only one answer. See, although nowadays we would like to diagnose it based on multimodality imaging, where we use OCT, then we are looking at fundus autofluorescence, but still the investigation of choice, because there is one hallmark finding that you have on an electrooculogram. So the investigation of choice is electrooculogram for Best's disease. Okay. So what is a hallmark finding? The hallmark finding is an abnormal electrooculogram despite a normal electroretinogram. Okay, because in almost all the situations you will have, whenever you have an abnormal EOG, there's always an abnormal ERG. But this is one condition where, in spite of an normal ERG, there is an abnormal EOG, or the other way around also. You do have an abnormal EOG, but that is not accompanied by an abnormal ERG. You get a normal ERG. Okay, so what is a hallmark of Best's disease? You have an abnormal electrooculogram in the presence of a normal electroretinogram. All right. Okay, so that is a clear cut. So the options were FFA, OCT, EOG, ERG. CRG definitely not, because ERG is normal. OCT, yes, we have a lot of nice findings you get on OCT. I'll discuss that on another day. FFA, not really useful. All right. Hi, Ram, Dr. Ram. Who's that? Hi, Deepak. All right. So moving on to the next question. Which of the following is not an ophthalmic emergency? I guess some of you didn't read the question properly. You were in a hurry to mark, because very many of you have actually marked orbital cellulitis and are surprised, because every day, almost every other day, we're talking about orbital cellulitis, and I'm telling you how important it is. Orbital cellulitis, you never let the patient go without treatment. Okay, never let the patient go without treatment, lost to follow up. It is an ophthalmic emergency, orbital cellulitis, which is the first option. The question is, which of the following is not an ophthalmic emergency? Okay. Option B, endophthalmitis. Again, endophthalmitis is a surgeon's nightmare, and it is an ophthalmic emergency. See, orbital cellulitis, it can turn out to be fatal to the patient. It is not fatal to the patient, but the patient will lose his eyesight. So we are worried. Okay, so it is an emergency. Acute primary angle closure, of course, the patient is coming to you with so much of pain and decreased vision. And of course, that is again an ophthalmic emergency, because that much amount of pain. Yes. Scleromalacia perforans, although the name sounds perforans as if, the globe is going to perforate, the globe actually perforates very rarely. Okay, it's actually a rare. That was once upon a time, it was a true or false statement. Once upon a time, in dinosaur ka age. Okay, so Scleromalacia perforans, although the name looks very scary, there's no perforation happening that commonly. Okay, it's a rare occurrence. Okay, so there's somebody who's posted a question. Bharat, can I take your question a little later? I'll finish all the doubts, all the questions, and then I'll answer your question, so that we're not lost with the flow. Okay, I've just discussed 2 questions, so please hang in there. Okay. So the next question is primary, secondary, and tertiary actions of inferior oblique. Okay, you need to know about all the muscles and their actions. Now, 2 muscles are very, very easy: medial rectus and lateral rectus, which they will never ask, because they have only primary actions. They don't have secondary or tertiary actions. Now, inferior oblique, they've asked primary, secondary, tertiary action. Okay, so the primary action of inferior oblique is going to extort the eyeball. So if this is my eyeball, it is going to rotate it outward. Okay, so the upper pole of the eyeball rotates outwards, that is extortion. Yeah, so primary action of inferior oblique is extortion, and always remember it is E plus E for inferior oblique. So that means the secondary action is elevation. I have taught you other tricks, the actual anatomy part in the conceptual videos, but right now you just remember inferior oblique, extortion, and next elevation. And this is an oblique has a B, so it is the B wala action as a tertiary action, which is abduction. Okay, abduction has the B, adduction does not have a B. So B for Bombay, B for oblique, oblique has a B, abduction. So whichever has this order, which is extortion, elevation, and abduction, so that would be the answer. Okay, because we are talking about primary, secondary, and tertiary actions of inferior oblique. So inferior oblique, you remember double E and the B. Okay, so extortion, so always oblique's primary action is a torsional movement or twisting movement. So torsion, extortion, then elevation and abduction. Got it into your brain box, all of you? At least inferior oblique. Okay, so the option here was B wala option. Now what was option A? Intorsion, depression and abduction. Intorsion primary action is superior oblique. Okay, now let's say what about depression? Superior oblique, depression is a secondary action, and again oblique, abduction. So option A, which says intorsion, depression and abduction, refers to superior oblique's primary, secondary and tertiary actions. Our answer is option B. I'm just discussing the other options. Now what about option C? Extortion, elevation, adduction. It's faltu. It's for none of the muscles. Option D, depression, extortion and adduction. See, depression is a primary action of inferior rectus. Okay, and what is the secondary action of inferior rectus? Inferior also is going to extort. Both the inferiors will extort. Okay, so inferior rectus primary action depression, secondary action extortion, which is option D, and the recti adduct. Which recti? The superior rectus and the inferior rectus, their tertiary action is adduction, because your oblique tertiary action is a B wala action, abduction. So superior rectus and inferior rectus has to be adduction, because medial rectus and lateral rectus don't have secondary nor tertiary actions, right? So option D in this case referred to inferior rectus actions. Okay, all right, moving on to the next question. Polychromatic luster is characteristic of. Polychromatic luster means the cataract is very colorful and it is shiny. Polychromatic, chroma means it is not the Tata ka chroma outlet. I'm talking about CHROMA. Chroma means color. Polychromatic, very very colorful, and luster, it's shiny. Yeah. So polychromatic luster is characteristic of option A, posterior polar cataract. Is posterior polar cataract, we know it's got an onion ring appearance, right? Concentric circles. There is no polychromatic luster associated with it. Posterior subcapsular cataract. Now some of you have been in a hurry to mark this answer, because there is a better answer in the option C. In option C, we're talking about complicated cataract. So the most specific answer for this term, polychromatic luster, is complicated cataract. You thought complicated cataract most commonly is a posterior subcapsular cataract, and you went ahead with posterior subcapsular cataract. No, posterior subcapsular cataract can be due to a lot more conditions. Like for example, a steroid-induced cataract is posterior subcapsular. That is not complicated cataract. Complicated means because of an eye degeneration or an eye condition. So textbook says complicated cataract has polychromatic luster, not generally posterior subcapsular cataract. So be very very careful. Like I keep telling you, whenever you arrive at the answer before option D, especially option A, but in this case it was option B, but thoda savdhan rakhiye. Okay, don't be in a hurry to mark, because just see, you marked, those of you who had marked option B, the best answer was option C, which is actually the correct answer. Yes. And option D, zonular cataract. See, zonular cataract, you know, has a steering wheel appearance or a cart wheel appearance, nothing to do with a polychromatic luster. Is that clear? See guys, in all these quizzes, it's okay. Even if you do on a GT, this kind of a mistake where you marked B without reading option C. Yeah, you mark the earlier options without reading the options which are further down. It's still okay. But you can't do this in your final exam, because your final exam is life determining. One wrong answer, guys, one wrong answer, and you slide thousands of ranks. And thousands of ranks means dreams are shattered. You can never recover from that. Okay, maybe you might settle down for something else, but all your life you'll have some kind of a little regret. See, maybe you will shine in whatever you choose to, but that dream of yours never shatter because of such reasons where you were in a hurry to mark an option. Is that clear? So now let me revisit whatever I told you. I said it's okay to make such mistakes in quiz and GTs. No, it's not okay. It's not okay, because when you're practicing in GTs, in your small topic tests or quizzes like this, which with no negative markings, never make such mistakes. Make it a something like a dictum in your head. You're doing an MCQ, you will always read 4 options, all the 4 options. Is that clear? So you will not be in a hurry. Okay, so again, so now we are revisiting the statement that I made. It is okay to make in quiz such mistakes. No, it is not okay to make mistakes in any of your practice sessions also. That is why you're doing practice. Yes, so today you made such a mistake, so tomorrow in tomorrow's quiz or tomorrow's whatever test you're taking, you should not make this mistake. Okay, so keep it in mind. Right, question number 5, laser used in smile procedure. Smile is your refractive procedure, no? Small incision lenticular exchange. Yes, or not exchange, extraction. Small incision lenticular extraction. So we are taking out a little bit of stromal lenticule. Yes, so it is a subtractive procedure where your corneal curvature is flattened, corneal shape is changed. Yes, so what is the laser that is used here? So all of you know it is femtosecond laser, but bad me, I can do such things, no, with you. Yes, so I have given you ND-YAG, I have given you ND glass, I have given you excimer, I have given argon green. So there is no femtosecond to be seen anywhere there. So what is it? ND-YAG, guys, ND-YAG punctures. It is photo disruptive laser. Whenever you want an otomy, you use ND-YAG. Okay, when you want an opening, a hole. Now I don't want a hole in the cornea, so I don't want to use ND-YAG. ND-YAG, seedha, it will make an opening. I don't want that. ND glass, neodymium glass, that is what is femtosecond laser. So femtosecond laser is basically an ND glass laser, yes, with a wavelength of 1053 nanometer. Again, photo disruption, but this is more precise. It just makes something like your stamp paper, but not like stamp paper. But 1064 is ND-YAG, Dr. Light. ND-YAG is 1064. So easy way to remember for ND glass or femtosecond is you remember the 1064 and ND-YAG, no? So from the 1064, from the 64, 6 minus 1, 5, 4 minus 1, 3. That's a very, very easy way to remember. Okay. Yeah. So that's a trick to remember, because these are both photo disruptive lasers, ND-YAG and femtosecond, which is ND glass. The correct answer here. Both of them are photo disruptive lasers. So ND-YAG, always keep it as a standard in your mind. That 1064 you should never forget. Okay, it's like 1947 is the year of independence. So like that, 1064 you never forget. So once you know 1064 ND-YAG, from the 64, 6 minus 1, 5, 4 minus 1, 3. So 1053 nanometer. Yes. So that is the answer for femtosecond laser or your ND glass, right? Now, excimer laser, guys, excimer laser is used in LASIK to make the stromal ablation. Yes, in LASIK, for the stromal ablation itself, you use excimer laser. Is that clear? Excimer laser with a wavelength of 193 nanometer, that is photo ablation procedure. All right, Bharat. Okay. Okay, right. Oh, it was a typo error. Okay, no problem. Anyway, now argon green is a photocoagulative laser. I'll talk about argon green in probably tomorrow's quiz. So I'll include one question. So yesterday, whoever asked for that one question leak, so laser, I made sure that you have a question on laser and we discuss a few things about laser. Okay. Krukenberg spindle is seen. See, yesterday I shared the link of that Instagram reel of mine where I posted Krukenberg image. And Krukenberg spindle was asked in this INICT November 2025 exam. See, now here Krukenberg spindle, option A, pseudo X glaucoma, not your excess, pseudo exfoliation glaucoma. Then option B, pigment dispersion glaucoma. Option C, ruled out, hypersecretory glaucoma, no. Option D, malignant glaucoma, again no. So your doubt is between option A and B, because certain textbooks say that there is a deposition of pigment on the corneal endothelium in pseudo X, but that is not what was the original description of Krukenberg spindle. So Krukenberg spindle was described with respect to the pigment dispersion glaucoma. So that is the answer. That is why I've got this. Some of you 50-50 you answered. Some of you have chosen pseudo X. Some of you have chosen pigment dispersion glaucoma. Krukenberg spindle, put in your head, one and only answer would be, best answer would be your pigment dispersion glaucoma. Now, in case there is one very rare possibility where you have two options, then probably you can even go for pseudo X. But again, there you don't call it Krukenberg spindle. We just say that there is pigment dispersion. Alright, yes, slide. So, it's not transillumination glaucoma. In pigment dispersion glaucoma, you also see transillumination defects on the iris. Why is that? Because in pigment dispersion, there is a posterior concavity of the iris. See, normally iris has to be like this, flat. But now what happens? It is posteriorly, it is concave like this. So when it is concave, it is going to rub against the lens. So when it keeps on rubbing against the lens, the pigment gets released, and that is where the pigment comes from, the melanin pigment. And so the melanin comes off the iris. So the iris will have these radial slit-like defects because of the loss of tissue, not just the melanin, the loss of the layer containing the melanin. So when you do a transillumination test, you will see the fundus glow through those radial defects. Okay, very good, Dr. Light, good that you said that, so I could discuss a little more about that. Now, malignant glaucoma and hypersecretory glaucoma we'll discuss on another day. I hope you watched that, you took a note and saved that. Please save that Insta post of mine, Krukenberg spindle. To list this exam, they asked you Krukenberg spindle seen in which condition. That means next exam they can ask you that image. Because see, when pseudo exfoliation, the target sign, the first time that image came, we were all flummoxed because that was definitely not something, it is at an undergraduate level. Because pseudo X is something you start seeing when you're a resident. See, maybe every other case you might see, because when you're doing the workup for cataract, you look for pseudo X so that you don't end up taking up a complicated case for your cataract surgery. Or as part of your workup, you need to find out all that. Right, but when the first time they gave the pseudo X target sign image in the exam, I mean, I really couldn't take it. I mean, what level are we going to? So now that means Krukenberg spindle is like nothing. If they can ask that Krukenberg spindle image, they can ask you. Okay, so please go and save that post. Keep it. Last minute revision, you can, it's very, very easy, because last minute you don't know what to see or read. Now, next question, ulcerative blepharitis may result in. Now, this turned out to be an easy question. Why? Because there was an option called all of the above. And immediately all went and chose all of the above. So, what is this all of the above? Which is actually the correct answer. Ulcerative blepharitis. What is ulcerative blepharitis? Ulcerative blepharitis is inflammation of the lid margin where you have tiny bleeding ulcers on the lid margin. Okay, unlike the oily crusts of seborrheic blepharitis or the dandruff-like flakes on in case of squamous blepharitis. So in this case, you have tiny bleeding ulcers. Okay. Now, option A says tylosis. Yes, there can be thickening of the lid margin, because when it heals, the skin margin, when it is there on the lid margin, when it heals, it has a scab, and subsequently there can be fibrosis of the margins, fibrotic healing. So you can have a thickening of the lid margin, tylosis. Option B was entropion. Yes, you can have a cicatricial entropion because of the scar at the lid margin. Now, suppose the scar is a little more on the skin side, a little more on the skin side of the lid margin. Again, you can have a ectropion. Now, you can have an ectropion, cicatricial ectropion. So, all of the above possible. Okay. Question number 8 was so very easy, but still I don't know how you could make such mistakes. I don't know. This is how you, probably you just got tired by the time you came to the 9th question. Stocker's line is seen in, guys, come on guys, Stocker's line, Stocker. I've always told you, remember stalker like that, stalker. STALKER. All of you know stalkers. Yeah, you have online stalkers, you have offline stalkers. Which structure stalks the cornea? The conjunctiva stalks the cornea, meaning it grows beyond the limbus on the cornea without the cornea's permission. Yes. What condition is that? Pterygium. Pterygium is a stalker. Yes. So yes, very good. It is the iron deposition at the apex of pterygium at the corneal epithelium. So it is very good, Bharat. Absolutely brilliant. Love you guys. Today's discussion is very nice. You're like interactive. Yes. Yes, Dr. Light. Very nice. So it is deposition of iron at the corneal epithelium at the apex of the pterygium. So it is in pterygium. And what about pinguicula? Pinguicula doesn't even come to the limbus. See, once something reaches the limbus, see, sometimes pterygium arises from a pinguicula. Now, in that case, anything which is, if a pinguicula is growing and it has reached the limbus, it is no longer pinguicula. Now it becomes pterygium. Okay. So, people who have marked keratoconus. What is the iron deposit you get in keratoconus? That is called Fleischer ring. Fleischer ring. Wilson's disease. Wilson's disease, there is no iron deposit. It is a copper deposit in the Descemet's membrane, and that is Kayser-Fleischer ring. Yes, that is Kayser-Fleischer ring. So, stalker's line seen in the stalker called pterygium. Put it in your brain box. Yes, everyone, those of you who even made mistakes, who didn't know, yeah, please. Maybe you're just new to ophthalmology and you attempted the quiz. I give it to you, give you the benefit of the doubt. All right. Now this question on astigmatism, somebody wanted me to leak. So there is one question on astigmatism today. So the question says, RGP lenses are used to correct. What are RGP lenses? Rigid gas permeable, RGP. Rigid gas permeable lenses are used to correct option A, regular astigmatism. No, regular astigmatism, why would I want a rigid lens? I can have a soft contact lens with the cylinder in it, which is called a toric contact lens. Yes, so I use a toric contact lens for regular astigmatism. Only when it becomes very irregular and I can't correct it using my toric contact lens, we go for RGP lenses or sometimes what is called scleral lenses. RGP is it's on the cornea. Scleral is, it's a big one. It will go beyond the limbus and rest. Okay. So RGP lenses are used to correct irregular astigmatism. That is the answer. Hypermetropia, no. If at all you want soft contact lenses there, na. Presbyopia, no. So RGP lenses are used to correct irregular astigmatism. What is irregular astigmatism? The surface is so irregular that you do not have one single flat axis, one single steep axis. There are so many axes, infinity sometimes, you can't even predict. Okay. So RGP lenses, so that is why in advanced keratoconus, we use RGP contact lenses. There are other indications as well. Yes. See, I'll come to your question, Sheikh. Sheikh and Bharat, I have two questions from you. I'll finish the quiz. We have one more question to discuss. I'll discuss that and get back to your doubts. Okay. Wernicke's pupil is seen in lesion involving. There are no two answers about it. Only one answer. Optic tract. Okay. Optic tract lesion produces Wernicke's hemianopic pupil. What we call hemianopic pupil. Now, there is just one more specific thing about it, which is whether it is a proximal optic tract or distal optic tract when we get a Wernicke's pupil. See, how do we describe or define proximal or distal is what you need to understand. The more closer it is to the occipital lobe or the visual cortex, that is considered proximal because the eye is considered as a extension of the brain. Okay. So, anything closer to the brain in the retrochiasmal structures, that is considered proximal. So, and you know, where does the pupillary light reflex fibers exit? Before the lateral geniculate body, just before the lateral geniculate body. So, from the chiasma, the optic tract goes to the lateral geniculate body, the visual fibers and the pupillary light reflex fibers. Now, the visual fibers will reach the LGB, but the pupillary light reflex fibers will exit the optic tract before the LGB. So, they are present in the distal optic tract but not present in the proximal optic tract closer to the LGB. I told you, the more closer they are to the occipital lobe or the visual cortex, that is considered proximal. So proximal optic tract lesion, there will be absolutely no problem with the pupil. Yes, because the pupillary light reflex has already left the system. It's like, if let's say something like, I cannot fail in a commerce subject at all because I've never taken commerce. I left mathematics. I mean, I did take mathematics in 11th and 12th, but I didn't have commerce or accounts in my 11th or 12th. After 10th, I see that went into science subjects. Na? So if somebody says Dr. Rajarathna failed in accounts, oh my god, no, accounts paper, see, probably I have, because of a number dyslexia, I can fail. Possible I can fail. But if somebody gives an accusation ki, arey, he to hamesha topper nahi thi, she failed in commerce and accounts. I'm like, arey bhaiya, maine liya hi nahi wo. I have never taken those subjects. I left that stream after 10th. After 10th, I was completely into science, right? So like that, in your proximal optic tract lesion, pupillary light reflex fibers are not even there. So when you have a lesion there, pupil absolutely normal. Okay. So that means the contrary is true. When you have a lesion of the distal optic tract, that means closer to the chiasma, there you will get Wernicke's semi-anopic pupil. Is that clear? Hi, A.K. Who is that? Anovar. Okay, Anovar, I guess. All right, hi. Okay, you got this? So, Wernicke's hemianopic pupil. This question says optic tract, but if you have any more specification, that would be, it is present in distal optic tract lesion. Is that clear? Okay. So, we have come to the end of the 10 questions of today's quiz. So, what was that doubt Sheikh asked? See, irregular astigmatism, you do have some treatments. Like, for example, to a certain extent, it can be managed with rigid gas permeable lens. And we also have customized LASIK that you can do, or PRK that can be done. I mean, to a certain extent. Now, suppose it is a nebula scar causing irregular astigmatism. Now, I can remove that nebulomatous scar by PRK, photorefractive keratectomy. Yeah. So I can use an excimer laser to smoothen out that Bowman's layer. So it can be done, or combine it with customized LASIK. So you do have some kind of options. Okay, may not be in all cases, and you can't give up also in all cases. Yeah, or for example, not for example, बस इतना अभी के लिए काफी है. Okay, Sheikh. So I hope I've answered your question. One second. Let me take Bharat's question. Bharat बहुत पहले पूछ लिया था. What was your question, Bharat? Ma'am, ethmoidal sinus orbit or is cellulitis is a... See, orbital cellulitis, most common cause, one-liners. Okay. You have to talk about children and adults. In children, it most commonly comes from the ethmoidal sinusitis. The ethmoid sinus has a lot of bony, the medial wall of the orbit has a lot of bony openings, communication with the ethmoidal sinus, and that makes sure that any inflammation in the ethmoidal sinus communicates to the orbit. So ethmoidal sinusitis is the most common cause of orbital cellulitis in children. Okay. Okay, what does Dr. Light ask? Oh, hi. How? Oh God, yeah. Yes, Dr. Namita, right? I know. She's the reason I am in ophthalmology. In fact, there's a very, 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 very funny story. Maybe someday we will do, like somebody asked, we'll do a podcast. There's so many things. I can't stop raving about Dr. Namita. Ma'am, she's absolutely, she's a stunning woman, boss lady that she was. And I think she is still. All right. Okay. So, guys, tomorrow again we will have all topics ophthalmology quiz, and one more question on laser tomorrow. I will make sure that we include. All right. Oh, lovely. Okay, good. I'll good that you mentioned that I will ping her today. Nice. Okay. So, guys, I hope you learned a lot in today's session. So, today I have posted some very nice image based question, very easy question also. So, try to attend that, answer that. I'm going to give a free subscription to people who are regularly posting their answers on Instagram questions, because we're taking a lot of trouble to give you such questions. So, please make sure you answer also, that will boost your confidence. And let's see how long, how many people are answering regularly, and to all the regular comments, we're going to give free subscriptions, okay, on iMentor app. And also, guys, today there is a, I know I'm always late because we are doing a 9 p.m session, and that is when I can tell you. So today there is a super Saturday sale, and that means you just got some 3 more hours to go. So got some, again, some nice discounts on the iMentor Dr. Rajarathna app. And if you want any extra discount at any time, please do reach out to me. Okay, my WhatsApp number is always there. You can reach out on the app. The staff tells me, so I will reply to you. Okay, so we will try to give you the maximum discounts that are possible from our end. Yeah, you're most welcome, beta. So the Super Saturday sale is on 3 more hours or even less than that. So make good use of it, and let me know. Okay, see you tomorrow, guys. Bye bye. Good night.